Hello, class. Welcome to Flourish Nursing Academy. This is Tutor Godwin. I'll be discussing esophageal atresia. Esophageal atresia is a congenital discontinuity of the esophageal lumen, is known as esophageal atresia. Tracheoesophageal fistula. Abnormal communication between the trachea and esophagus. Epidemiology 1 per 2,500-3,000 live births. 50% have one or more associated anomalies: cardiac, anorectal, genitourinary, vertebral, or skeletal, and others. A 2% risk of recurrence is present when a sibling is affected. Increase in advanced maternal age. Embryology. Both the esophagus and trachea originate from the primitive foregut. Stages in the development. A. The laryngotracheal diverticulum forms as a ventral outpouching from the caudal part of the primitive pharynx. B. Longitudinal tracheoesophageal folds begin to fuse toward the midline to eventually form the tracheoesophageal septum. C. The tracheoesophageal septum completely forms. At week 4, the tracheoesophageal diverticulum developed into a tracheoesophageal septum. There is a failure of separation in the septum, leading to a fistula. During week 8, the primitive gut failure of recanalization leads to pathogenesis unknown. Occurs sporadically. Multifactorial, multiple genes, and complex gene-environment interaction. Theories: 1. Esophageal occlusion and failure of recanalization. D. Spontaneous deviation of septum. 3. Teratogen doxorubicin classification. According to the system formulated by Gross, type A esophageal atresia without fistula or pure esophageal atresia, 10%. Type B esophageal atresia with proximal, TEF, less than 1%. Type C esophageal atresia with a distal TEF, 85%. Type D esophageal atresia with proximal and distal TEFs, less than 1%. Type E TEF without esophageal atresia or H-type fistula, or 4%. Type F, congenital esophageal stenosis, less than 1%. Pathophysiology. A fetus with esophageal atresia cannot effectively swallow amniotic fluid. Polyhydramnios. Premature labor. Aspiration of saliva or milk, if the baby is allowed to suckle, can lead to aspiration pneumonitis. In a baby with esophageal atresia and a distal TIF, the lungs may be exposed to gastric secretions. Also, air from the trachea can pass down the distal fistula when the baby cries, strains, or receives ventilation. This condition can lead to overdistension of the abdomen, which ultimately may cause acute gastric perforation, which is often lethal. Diagnosis. Antenatal diagnosis of esophageal atresia is done during routine maternal. Ultrasonography. Polyhydramnios. A small stomach. A distended upper esophageal pouch. Premature clinical diagnosis. Excessive drooling. Copious, fine, white, frothy, bubbles of mucus in the mouth, and sometimes the nose. If these signs go unnoticed, the first sign is almost cyanosis, accompanied by coughing, choking, and afterbirth. These babies often appear to blow bubbles when attempting to swallow mucus and saliva. Signs and symptoms of respiratory distress due to aspiration pneumonia. A. Diagnosis of esophageal atresia is confirmed when a 10-gauge French catheter cannot be passed beyond 10 centimeters from the gums. B. A smaller caliber tube is not used because it may curl up in the upper esophageal segment, giving a false impression of esophageal continuity. Investigations first line. Investigations: plain radiograph, esophagogram, endoscopy. Others: renal ultrasonography, echocardiography, bronchoscopy, laboratory investigations, renal ultrasonography. To evaluate associated kidney anomalies, ureteral anomalies, or both. Echocardiography, which has clinical signs of cardiovascular disease, management aims of management, prevention of aspiration, pneumonia and its consequences. Establishment of communication between the proximal and distal ends of the esophagus. Separation of the esophagus from the trachea. Preoperative management. The oropharynx should be cleared. The infant's head should be elevated. IV fluids and nutrition. Oxygen therapy. In infants with respiratory failure, endotracheal intubation should be performed. Broad-spectrum antibiotics. Timing of surgical correction. A. Immediate primary repair. 1. No pulmonary complications, viz. Severe pneumonia. An arterial partial pressure of oxygen in arterial blood greater than 60 millimeters of mercury in room air, not associated with major congenital malformations, which are compatible with life. The gap between the proximal and distal esophageal pouch is less than 2.5 centimeters. B. Delayed surgical intervention associated with pneumonia, sepsis, or cardiac malformation. Severe prematurity. The gap between the proximal and distal pouch is more than 2.5 centimeters. C. Staged operation. The indications are if primary repair cannot be done due to the reasons mentioned in the delayed surgical repair, failed. Long gap between two esophageal pouches, viz. In type 1 esophageal atresia, where the gap is usually more than 3 to 4 centimeters. Stages of surgical correction. Left cervical esophagostomy and feeding gastrostomy immediately after birth. Thoracotomy and ligation of tracheoesophageal fistula. Replacement of the gap between the proximal and distal esophagus by an isolated vascularized segment of colon or by a gastric tube. Complications: ATEAT early. Pneumothorax anastomotic leakage. Recurrence of fistula. Pulmonary atelectasis or infection. B. Late. Anastomastic stricture. Gastroesophageal reflux. GER. Tracheomalacia. Disordered esophageal peristalsis, dysphagia. Follow-up. After surgery, children and their caregivers will continue to visit specialists for ongoing care. Success in treatment often depends on the follow-up to monitor growth, development, and possible late complications like GER or esophageal stricture. Patients are often seen by a multidisciplinary team including gastroenterologists, pulmonologists, and nutritionists to ensure comprehensive care. Regular evaluations help to catch and address any arising issues promptly. Living with esophageal atresia. With proper treatment and follow-up, most children can lead normal lives. Parents are encouraged to maintain communication with their healthcare team and seek support from others who have shared similar experiences. Creating a supportive home environment, learning about condition management, and staying informed about the latest in medical advancements contribute greatly to a child's quality of life.